Welcome back to Inside the Wellspace, the podcast where we gather in community to have the conversations that matter most to women's lives today. I want to begin with a question for you. When was the last time you felt truly seen, heard, and supported in a doctor's office? For far too many women, the answer is complicated because reproductive health care is not just about medicine. It's about dignity, access, and trust. And that's exactly what we're diving into today. My guest, Nikki Vinckier, has spent more than a decade as a reproductive health care provider, serving women one-on-one in the clinic as a trauma-informed OB-GYN PA. But her journey did not stop there. From witnessing firsthand how gaps in care and systemic barriers leave women vulnerable, to stepping into national advocacy, especially after the seismic shifts in 2016 and the overturning of Roe v. Wade in 2020, Nikki has become a vital voice in reproductive rights. Her work has become covered in major outlets, her advocacy has challenged institutions, and her new book, We Deserve More, makes a powerful case for rethinking the way we care for women's bodies and lives. In this conversation, we'll talk about everything from the myths and the misinformation circulating on social media, to what it means to prepare for your gynecology visit, to how trauma weaves its way into both patient and provider experiences. And most importantly, what it will take for women to reclaim trust in our healthcare. So, let's get started. Nick.
Hi, what a great intro that was. Thank you so much.
Well, it's all about you. It's all about you. And I just wanted to say thank you so much for coming here and sharing yourself with us, because what you do is so important. Thank you for it. So we've got a lot to talk about because you have a lot going on and a lot to say, and you're doing a lot. Why don't we start by, can you tell us your story? Tell us what you do.
Yeah, so I'm an OB-GYN physician assistant, as you had shared. I'm born and raised from California originally, and I never thought that that part was all that exciting. And then my partner is from Michigan, and so I had actually gone to undergrad at University of Michigan.
Go Blue.
Yeah, go Blue. Didn't meet my partner until later when I was living back in California. And then we decided after I graduated PA school to move back to Michigan, and I started practicing medicine here. And that's when I started realizing and learning the landscape around me, that what I was doing was pretty politicized. And I started practicing medicine in 2016 and as a PA in OB-GYN, and within a few months was the first election when Donald Trump won.
You could just call it the election, because that's the pivotal moment in our lives, really. Yeah,
I think like the awakening for so many people, where we all really realized that things were much worse than we had thought. I think I went to the voting booth so excited to vote for Hillary Clinton, thinking she was going to win. We were going to have our first female president. I really felt that way.
I feel like we all felt that way. A lot. Yeah. Many of us felt that way.
Yeah. And then when we lost, it just became so apparent over the next 4 years that practicing reproductive healthcare was complicated here in Michigan and in the United States. And then in 2017, I found out while I was practicing that I was pregnant with my first child, and it was a son. And I found out it was a boy the same day of the first accusations of Harvey Weinstein.
Oh, wow.
And so
Heavy.
That was an interesting thing and heavy. And then in 2020, I was pregnant with a daughter when Roe versus Wade fell. And then in 2022, I was on maternity leave with my third kid. And that was when in Michigan, we were the first citizen-led ballot initiative. So all this time, I'd been practicing reproductive health care as a clinician and really enjoying it, and started realizing, hey, I need to be using my voice, because the clinical voice was really missing from the conversation, it felt like, here in Michigan specifically, and in so many states.
Yeah.
Because it's not easy to practice that, and it's really not easy to put yourself out there and speak about it.
It's not, is it?
It's not.
Let's like really just take a minute to appreciate that, because it's a big deal to put yourself out there, own what it is you're saying, and really advocate for people. So thank you for that.
Thanks.
Yeah.
Yeah. And I don't blame anybody who doesn't.
Mm-mm.
And especially for the clinicians, like there's a big safety concern as well.
Yeah.
And so I really respect the people who do choose to stay, kind of out of the spotlight, if you will, especially in reproductive health care. But yeah, then over the last several years, I started leaning more into advocacy work. And so I was working full time as a clinician and a new mom of 3 young children, and then started getting more involved in the reproductive healthcare landscape and advocacy on a state-based level, then on a national landscape. And it's really interesting being in Michigan because it's such a polarizing swing state
Yeah.
where our votes and our voices really do have an impact. And so I started using my voice more.
Wonderful.
And it's been a journey. And so now I have gone from practicing clinical medicine where I was one-on-one with patients in the exam room to really more focusing on thought leadership within the space, talking about reproductive health care in general,
Yeah.
not just abortion. So all of reproductive health care and what that encompasses. And I started an organization called Take Back Trust, which I'm sure we'll get into.
Yeah, definitely.
Talks all about education and empowerment within the reproductive healthcare landscape.
Great.
That's a little bit of how I got here today.
Yeah, that's, a wonderful story. And the fact that you are in such an important location geographically and that you're using your experience and voice where it matters is commendable. Totally. Let's take the umbrella of reproductive health care, because one of the things that we talked about before was reproductive health care umbrella, everything that goes on underneath it, and the theme and thread that what your work has been trauma informed. Can you just sort of go into that a little bit for all of us around reproductive health care in general?
Yeah, so there's so much in terms of reproductive health care and kind of what's missing in it. And again, I don't blame anybody. There's so much to cover and it all gets kind of put together. Like, for example, when it's the same doctor who does our breast exams and diagnoses us with breast cancer, who cares for our pregnancies, who is managing our menopause. Like these are all completely different things.
I know.
So there's a lot that gets left out.
I feel like they should be called our GPs, shouldn't they? Because really, for the female body, that is you just named them.
Yeah, I mean, that's the problem, though, is that they're not GPs.
Right.
So many people treat them like they're GPs,
Yes.
which puts more on their plate.
Yes.
And so it ends up being actually, I think that's problematic that women are treating their OB-GYNs like they're a GP because they're not supposed to check your cholesterol and they're not supposed to be managing your blood pressure and they're not supposed to be doing kind of your yearly screenings.
Right.
So I do think that that's a bigger issue. But part of my focus and really what I've come to learn is the trauma-informed lens and how that has been missing from gynecology. And so I've seen it play out so many times in getting my own healthcare, which so many of us as women and people with uteruses have experienced, and providing healthcare for people while they're in that moment.
Yeah.
And so the way that I used language while as a clinician was always important to me, and it was always consent-based. And that's really lacking in gynecology. And so for so many people who do have a history of trauma, there isn't enough empowerment that's given to them in the moment. And it's kind of this just hurry up and get done with it kind of concept.
Like white knuckling it, right?
White knuckle it and get through it.
Right, because we know, right? We know 1 in 3 women has been sexually assaulted. 1 in 3. So why wouldn't it? Why? You're absolutely right. There should be that thematic over.
But this is wild. Less than 8% of women actually disclose that trauma when they're with their gynecologist. 8%. So it's right, 1 in 3 women, so 33% of women have experienced trauma. Less than 8 are actually reporting it. So clinicians in general have this gross misunderstanding and misrepresentation of what their patients are actually coming into the room with.
Yeah.
Because patients don't disclose it.
Right.
And again, I see both sides, But how do we provide the best possible care when people aren't disclosing it?
Right.
And it's by assuming that everyone has a trauma history. That's what
Just make that assumption, right?
you have to assume that,
Yeah.
unfortunately.
You mentioned when we talked before too that doctors just aren't trained in that either. It's not part of the curriculum, is it? The whole concept of trauma-informed anything.
No, it's not. And you have to seek out additional care on your own. And there are amazing organizations that are doing it.
Mm,
But aside from that, it's like you have to seek out the training and then you have to put it into practice.
right.
And the problem is that we're all running late. We don't have enough time. And frankly put, trauma-informed care does take additional time. It does take additional steps.
Yeah.
And that's okay. But we need to make time for
Right.
that as clinicians, right? We need to assume, we all get into these patterns of having almost like a script that we say during pelvic exams. And our script needs to shift to be more trauma informed and trauma inclusive.
Yeah, I agree with you. I know I'm just like thinking about it as you're talking and thinking about what have my experiences been. And, it's definitely not trauma informed, that's for sure. Uh-uh. Is Take Back Trust part of that? What is Take Back Trust for everybody to know about? Because it's great.
So Take Back Trust, I had been part of the Creators for Kamala campaign, which was really fun this past fall. And again, was hoping we were going to have that female president. And when we lost, I started all of a sudden getting text messages from friends, family saying, "Hey, Nikki, what do I do about this? Hey, Nikki, my IUD is set to expire, in a year. Can I change it out early? Hey, Nikki, I have frozen embryo in a red state. What do I need to do about that? Hey, Nikki, is it safe to be pregnant right now?" So I had all these
Wow.
questions of people that were texting me with this concept of, we saw how bad reproductive health care got from 2016 to 2020 and then the residual effects after that. And so almost this like pre-planning of people wanting to know, okay, what can I expect over the next course of several years?
Right.
And so Take Back Trust was really built to inform people about what we're experiencing in our current landscape, what we're expecting, and how that impacts and plays into your healthcare. And the main reason why that's important is there wasn't really anywhere where that was living online.
Mm-mm.
Like you could find information about getting an IUD, but it doesn't really talk about, okay, if you want to get your IUD replaced early because we're worried about IUDs being pulled from under us, how do you do that, right? So like specifically kind of addressing the nuance of today's landscape within our gynecological healthcare. And so that was part of it. It talks a lot about contraceptives and abortion. And again, while we're talking about the umbrella of reproductive health care, there's a lot where abortion is kind of outside that umbrella. And so part of what my goal was strategically with Take Back Trust was, if we're looking at an umbrella of gynecological health care, abortion is underneath that umbrella.
Yes.
It shouldn't be on an island by itself.
Why is it?
And so,
Is it on an island by itself?
oh, for so many reasons. Number one, most clinicians and OB-GYNs don't provide elective abortion care.
Anymore. They just
And-
can't because they can't.
Yeah. Or they don't want to, or the risks aren't worth it to them,
Right.
or they have qualms and personal conflicts, or their
right.
hospital doesn't allow them to.
Right.
They practice at a Catholic hospital, X, Y, and Z, right? There's
Right.
a million reasons why
Gotcha.
that doesn't happen anymore. Additionally, we've kind of done a disservice of talking about abortion on its own as elective abortion only,
Right.
rather than talking about how abortion and miscarriage are actually one in a same,
Yes.
they're two peas in a pod kind
Yes.
of thing.
Yes.
And so really inappropriately, I think, separated them rather than letting them be kind of connected in the way that they are. And so we see this play out all across the US, that people aren't getting the miscarriage management that they should be. We see it with the politicization of mifepristone, which is a medication used for medication abortion that's also frequently used for miscarriage management. If we didn't have abortion on an island, if we could keep it under the same umbrella, then I think we'd have more success with mifepristone being like more generally recognized as medication used for both miscarriage and abortion. And
Right.
so
Got it.
I think the concept of the island versus under the umbrella is really important.
Mm.
And it's just, I don't think we did it. I think it got pulled out strategically by decades of the anti-abortion movement, where
Makes
they have
sense.
been breaking down, hey, this thing, right?
Yeah.
And so I don't think it's anything we did within those of us in reproductive healthcare. I think it's been something that it's on its own island because of the politicization of it.
Got it. Okay, thank you. That makes sense.
Mhm.
Okay, so under the umbrella, we're talking about what should women be thinking about as it relates to reproductive health care now when birth control, for example,
It kind of depends on the stage of life that you're in.
Mm.
There's no like, what should women be thinking about in general, right?
Right.
Because if you're 18, you're thinking about different things than if you're 30 and trying to get pregnant, and you're thinking about different things than if you're 45 and in perimenopause than if you're 60 and postmenopausal.
Right.
So there's no easy answer for what should women be thinking about when it comes to their reproductive health care. But what is important is that we need to know that the system isn't working well for us. And so I guess then the answer for that is what we should be thinking about is the fact that we actually need to come into our visits prepared with questions.
Right.
We actually need to be the ones to kind of take the reins on our own healthcare, specifically around reproductive healthcare, to get what it is we need. We see that, for example, with menopause. We
Yeah.
see so many clinicians are deficient or uncomfortable in prescribing things like HRT. And there's this like stigma that gets perpetuated with menopausal care and management. I don't necessarily say, hey, Google is better than your clinician, but I do think you need to learn more about it. And if you're not getting what you need from your clinician, then I think it's time to find a new clinician
Yeah.
or find a supplemental clinician
Right.
who can address those
Right.
things.
That could be specific about whatever it is you're looking at. As a practitioner, what would you want us to come prepared with? What is the best way to walk into an appointment?
Yeah, great question.
Thank you.
So that was one thing that we do on Take Back Trust is we have a provider visit planner.
Oh, great.
So it has, depending on what stage you're in, questions that you can come in prepared to ask your clinician. So if you're interested in learning more about contraceptives, what specific questions you want to know, right?
Okay. Yep.
And that's broken into a million things, whether you're interested in birth control or IUDs
Right.
or what your family planning needs are, if it's just for management of heavy periods, things like that, versus family planning, right? All those different pieces. So I do think it's taking time to really almost self-triage and self-reflect and evaluate what your needs are and what you're trying to get out of the visit before you go into the visit.
It's so smart.
And writing them down, taking 5-10 minutes before your visit and having them written down, because we know we always forget things when we're on the hot seat and
Totally.
naked and sitting in those stirrups.
Oh my God.
So have them like on a
Worst.
notes app on your phone or on a piece of paper, so that then that way you have them. So when you leave, you feel like, okay, all the things you wanted were addressed.
Yeah.
Another thing that's really important, kind of like what we were talking about the misconception that so many people treat their OB-GYN as an P, is so many people think that their annual exam time is the time where they're going to get all their questions asked.
Right.
And that's one thing that I think is really important to understand, is that if you have problems that are coming up, if you have issues that you're experiencing, heavy bleeding, perimenopause, X, Y, and Z, that needs its own problem visit so that you can go in for a specific visit. Because what's happening is women are coming in for their annual exam to get their breast check and their pelvic exam. And then they have this laundry list of 17 questions that they want to have answered. And they're frustrated when their clinician doesn't answer them. But we need to understand better how the system actually works. And a preventative annual exam is not made, unfortunately, to answer those questions. So if you have questions, you need to schedule a separate visit to address those questions.
Okay.
And so that, I think, is a really important thing that isn't fully explained to us. Like, how do you experience healthcare? How do you show up in healthcare?
Right.
And even just like booking the right appointment is a really important first step.
That makes such sense and is very helpful. But what is most interesting to me about Take Back Trust now is that there's a place that we can go and look at all of this stuff too for our own selves. And
Mhm.
it's also coming back to just thematically what I think about for women, and I think about just for us in terms of becoming stronger for our own selves, showing up for our own selves, is knowledge. What you're saying is empowering. It's saying, you know what? Just like research for yourself.
Yep.
The research for yourself, because it's for you. Don't walk into any doctor's appointment thinking you're walking into the answer, because you're not. Like, you have to ask the questions because you know yourself better than anybody, right?
Yeah.
Like, in
And I
every
think
way.
and I think that that's so important. I don't think you should research in lieu of seeing a clinician.
Mm-mm.
I think you should research to support the visit that you're going to have with a clinician.
Yeah.
And so when and I think when you're researching, you need to really be looking at, okay, what is the quality of materials that you're actually reviewing? Because turns out that there's a ton of
Ugh,
mis and disinformation online. And so a lot of people will come in being like, I did my research, but the research is not like scientifically backed.
right.
So I think that research hygiene is also an important
I
thing
love
worth
that.
discussing.
Research hygiene.
To
That is
make sure
such a
that you're,
cool
like,
thing.
actually getting appropriate information and setting guardrails, right?
Yeah.
Like ChatGPT.
Yeah.
We have You can get anything you want out of that.
Yeah.
But instead of allowing ChatGPT to let you spiral into this like rabbit hole, what you could do is train your ChatGPT to say, hey, I have a visit with my clinician coming up in a week or two. Like, what questions could I be asking that clinician
Right.
to help get in the right mindset? Like,
Right.
what are the differential diagnoses that I could be asking about? What are other things I should be considering?
Right.
Right. Like, instead of being like, "What's my diagnosis? What do I have? And what tests should my doctor be running?"
Right.
We need to figure out the whole system and
Uh-huh.
ecosystem of, like, how do we do research better when most people experiencing healthcare aren't researchers?
Correct. Correct. I love the guardrails on ChatGPT too, and data hygiene. That's awesome. I wonder too, with ChatGPT, you can ask to only give you information from clinical studies, basically, as opposed to just combing the web, right? Like, I only want data from studies yes, correct. Okay, see,
Yeah.
that's a great tip. That's a great
Yep.
tip. Is there a place that you like to go, a particular repository, WebMD, whatever? I don't know the answer, that you suggest people might find things they want to hear?
Yeah, there's a million different options kind
Yeah,
of depending on as clinicians, we use something called Up to Date, but that's not widely available for
got it.
people. I do think that I hate to say it, I do think ChatGPT is not terrible when it
Good.
comes to some of these things.
Great.
Uh,
That's easy for us then. That's
yeah,
very easy.
I think some of the Googling is fine when you were looking for, like, queer specific sources, trauma informed sources, right? Like, those are absent and missing in the general database. So
Mm,
that's the problem. Is
gotcha.
like, if we're looking for more specific, nuanced, appropriate care for
Mhm.
certain demographics, that's not going to be what's given to you on
Yeah.
some of these standard research.
Got it. Okay. No, but this is super helpful. You wrote a book?
I did.
You wrote
Yeah,
a book, and it is called We Deserve More, yes?
it is.
And it's coming out next year, and we'll talk about it when it comes out too. But can you tell us, tell us about it and how it all came about?
Yeah, this has all happened by accident. I feel like
Amazing.
all of my advocacy work has really happened by accident. This feeling of being like, I happen to be in the right space at the right time. And I have this like impulsive brain that never settles. And so I just start thinking about all these things that aren't working the way that I think they should be working, which many would also call anxiety.
Oh my God. Adult onset ADHD for women, right?
Literally.
Yeah, I can relate.
It all kind of stemmed out of Take Back Trust also, and this feeling of how do we get it into the hands of more people? How
Yeah.
do we support women and people with uteruses as they're experiencing reproductive health care? And a lot of it is what we've already been talking about of like, how do I teach you what I've learned from 10 years in the clinic of being like, hey, we're missing these things. Hey, this isn't coming across to the general public. And if you don't have a clinician who's taking the time to explain this to you, what would I want you to know? And so that was kind of like where I came from with both Take Back Trust and the book is okay, let me tell you the first part of We Deserve More is let me tell you what I feel is missing from some of the clinical education. And to be fair, I didn't go through residency. I'm not an MD, I'm a PA. Very aware of the limitations of my experience. And I also that presents this interesting nuance where I'm in the system but not through the system.
Okay.
And so I think that there's a little bit it's just a little bit of a different landscape.
What does that mean though? Like in terms of how does that affect the way you look at it?
It's critical of the what's missing in residency
Mm-hmm.
because there's just so much that they have to cover
Mm-hmm.
that I think a lot of the relational parts of care get left out.
Got it.
Yeah, so it talks about some of that piece of what's missing,
Mm-hmm.
some of the kind of pain management approaches, some of the menopausal management, the trauma-informed care that we're talking about, the bedside manner that we're talking about. There's so much emphasis on having surgical skills that some of that GP type concept, that relational parts of care
Mm-hmm.
get deprioritized within training.
Oh, interesting.
Oh, yeah, that I think translates into some of these other things that we're seeing. Additionally, we know the history of gynecology is atrocious. So who's commonly called the father of gynecology, Dr. Sims, practiced his initial surgeries and surgical skills on anesthetized enslaved Black women.
Unanesthetized?
Unanesthetized. Yep. So there are 3 women that we know for sure, Anarcha, Betsy, and Lucy. And then there were up to 30 enslaved Black women that he practiced these skills on, and then went on to do them to white women with anesthesia.
Horrible.
Horrible. Absolutely horrible.
Oh
So when
my
we
God.
talk about kind of pockets of pain management, when we talk about Black maternal health care, when we talk about how Black women aren't getting the pain management that they deserve, when we talk about kind of like in general, when any woman goes into a clinic and talks about her pain,
Mm-hmm.
it is rated as lower than their equivalent male's pain. And Black women is rated even lower. Like if for some reason clinicians don't believe Black women when they talk about the pain that they experience.
Ugh.
And that is systemically built into the biases in medicine, right?
Right.
And so then you look at how that kind of plays into the whole system.
Mm-hmm.
And so the book talks about that quite a bit.
Good.
And then it talks about part 2, like what does this actually lead to?
Right.
And a lot of it is this mis and distrust within the healthcare system, rightfully so, how culture kind of steps in to fill some of these voids. So we see that like certain shows are now having to step up and thankfully, right? We talked
Yes.
about this the other day.
Yeah.
Grey's Anatomy has done a great job. The
Yes.
Pit has done a
The Pit
great
was
job.
great. That was
The
so
Pit is
good.
great
Oh, I
at
loved it.
showing some of the nuances of bias in medicine
Yeah.
and how different people experience different care levels, point
Mm-hmm.
blank. And we talk about the rise of social media and why people are turning to TikTok and Instagram for things. We talk about ChatGPT and how you can just like learn all your symptoms online.
You
right?
can. Yes. Now is the time. We know more about ourselves. We can know more about ourselves than ever.
Exactly. And then part 3 is, okay, if you're learning about yourself, what do you do with that?
Right.
Like, how do you actually
Right.
engage a little better? What are those steps to prep for a visit?
What
How do we
now?
ask
Right.
better questions? How do we learn more about the different appointment types you can be booking?
Mm-hmm.
And so it kind of talks a lot about the themes that we've kind of talked through in this podcast so far.
I'm so glad about that because it's always the, okay, what next? Now, what do I do with all of this? What is the best next step I can take for myself? For myself. You said earlier too, if you're not getting what you want or what you think you need from a doctor, a clinician, whatever, find another one.
Yeah.
Right?
Yeah. Yeah.
And
But as women, we don't do that
no,
is the problem,
no,
right? And
no.
I even mentioned this in the book. There is this whole trend of people on social media who won't tell their nail technician that they don't like the color of their nails, right? Or they don't like the shape of their nails. And it's funny because it's relatable also,
Yeah.
right? So if we are not telling our nail technician
Yeah.
that we don't like the shape of our nails,
Yeah.
then I can guarantee you people aren't telling their healthcare clinicians that they're not getting what they need.
Right.
Right? And it's this like
What
sit
is
down and
that?
swallow it,
Yeah.
this like passive, you must
Mm-hmm.
be obedient in the system.
Yep.
Like, don't buck the trend, don't make noise, don't stand up. Like, we've been as women so suppressed for
Yep.
so long
Yes.
that
Yes.
I think if we're seeing this in a nail salon, like expand that into our healthcare.
Yep. Yep. Okay, total tangential. I just read a book called Fawning by a Dr. Ingrid, Carlson, the name. It was phenomenal. And it's about not necessarily that specifically, but about how we as women practice certain behaviors just because we feel like it's safe. It's the safe way to get by. It's a way to exist, to exist basically. Oh, to not be in conflict or, it's fascinating that it really all comes full circle back to that, doesn't it? That,
Yeah, it's
again,
patriarchy.
patriarchy and the fact that gynecologically we have just not been studied. The fact that hormones and menopause and perimenopause and the whole span of what that is for us is still not enough, not known.
The NIH says that 8 to 11% of funding goes to female-related things.
Hmm.
That's it. Less like 10%. That's it.
Yeah. And last I checked the stats, we're 50% of the population globally.
I mean,
Just saying. Yeah. Uh-huh. Yeah. And I think the stat also is we're responsible for something like 85% of the spending that goes on.
oh, I wouldn't be surprised.
Yeah, it's a good one. It's a really good one. That's a good stat.
Yep. So that's an interesting thing, actually, that when we look at perimenopause
Uh-huh.
and menopause, when we relate it from an economic standpoint,
Yeah.
we can get a little bit more traction on it, actually, because people care more about spending
Yeah.
and more about the impact to our
Yeah.
economy than they do about the female experience.
It's true. It's really all how you spin it, isn't it? So if we just all talked about or made our choices, with our spending, I don't know how we do that. We got to galvanize that. We got to figure it out. So this is great. So your book is out when? In next year?
Yeah, it'll be June 2026.
Awesome. That's exciting.
It is exciting. I'm excited to have it out. I'm excited to have more people share it, experience it. I think, when you talk about how do we expect better things for ourselves,
Yeah.
I think that that's a big one.
Yeah.
But I also think, too, sometimes we don't think about it enough for ourselves.
Yeah.
I think another way we can think about it, too, is like, what do you want to share with your best friend?
Mm.
And when we think about it, females are so loyal and wonderful.
Yeah.
And if we can think about like what knowledge can you learn to impart on your best friends too, it becomes not just about yourself. It becomes about how we as a community, as a cohort can experience reproductive health care.
Mm.
So I even write in the intro, I'm like, man, take this book and send it around your friendship group. Make it a sisterhood of the traveling pants type of
Yes.
style.
Yes.
Right? Is that I think that if we
Yes.
think about it not just as for myself,
Mhm.
but also for myself, for my sister, for my best friend.
Totally.
that's where I think we can really radicalize reproductive health care, because people are really passive about their own experience,
Yeah.
but we're possessive of our best friends.
Correct.
Right? And if
Yes,
I talk about like
correct.
what I want my best friend to go through, that's a big part of why I wrote this book.
Love it.
Is my best friend has been experiencing miscarriage after shitty experience in the healthcare system.
Ugh.
And she'll send me these text messages being like, "Can you believe this? And this is what's happening." And I'm like, putting it in the book. It's in the book.
I love it.
So in a way, like this book is kind of my like love note to my best friend.
Good.
And I would like for so many women to feel that way for their best friends,
Oh,
right?
my
Because we can
God.
advocate for ourselves, but we can also advocate for our sisters and for our friends. And if we take that on, that's how I think we can enact more change.
That is fantastic and palpable. I mean, like that's, you can do that and you want that. And you
Want that.
you want
right?
that and you know.
You've been swallowing it for however long and you're just like, whatever, in a way.
Yeah.
And like we want more for ourselves, but I really want more for my best friends.
100%. Yes, and your daughters. And your daughter and her friends. I spend a lot of time. I mean, I spend a ton of time with my daughter. She's 24, and her girlfriends. And I share stuff with them. I forward things to them. I want them to know they have time. They have time, and they can make change. They can do something.
Yeah, and it's tough for them. Right?
Yeah.
And I don't. I mean, all of us experienced poor sexual health education in schools. It's all bad, still bad.
Yep.
And the fact that they're coming into reproductive years, while it is as politicized as it is it's really tough.
It is. My hope is that it will motivate them to speak up, speak out, become advocates themselves more, as women. I hope so too. I really do. I really hope so. And I mean, your book too is a book club book. It's a book club book. That's something that is worthy of great conversation amongst your girlfriends. I don't know. I have a group of girls that we read books, and they're generally thought-provoking topics that we need to, discuss. There's this book called It's All in Her Head. Oh, it's fantastic. But it will piss you right off because it's all about healthcare. And it's the history of the female body. This is what got me started too, just to being mad, to waking up. Like you said, it's an awakening. It like woke me up, and I thought, this is awful. This is just the way we've been non-treated, basically non-treated for forever. And diagnosed by men who have no clue about what it's like to be in a female body. None.
Yeah, I love that. I hope that that's the case, because I think that kind of goes back to the concept of how do we make this better for other people, right?
Yes.
How do we make this better for our friends?
Yes.
And if it does become a book club book, then you can almost like it's almost like a potluck of how shitty has your experience been?
Well, yeah.
Bring it to the table.
Let's talk about it. Forget about it. Like, yes. Right.
And how would we do it differently? How can we make it better? How can we talk about not just the book, but how can we destigmatize some of reproductive health care where we are trained to not talk about miscarriage, where we're trained to not talk about our periods, where we're trained to not talk about perimenopause.
Yes.
And we're really unlearning some of those things. And so if this becomes a book club book, then that's an amazing thing because it all goes hand in hand.
It does. Well, it does, though. And that's exactly it when you say we're trained to not talk about it. So I had my kids later in life. I have a son and a daughter. I was 36 with my girl, 38 with my son, and I had 4 miscarriages. Did I have 2? Yeah. 2 before, 1 in the middle, then 1 after. And no one talked about it. And it was like brushed off, like, no big deal. I was like, it kind of feels like a big deal. It feels like a big deal. Physically, too. I mean, like, oof, it's not fun. People did not talk about it. There are lots of things you don't talk about when it comes to postpartum. After you have your kids, what do you feel like? What's your body like? What should I be doing? Should I be eating things differently? What do I do here? I don't feel good. None of my doctors even asked the question. Not one asked the question.
They still don't. That hasn't changed.
I mean, I look back on all of it, I'm like, Jesus, I'm glad I'm still here. Like, it's like you've gone through a war. I mean, it's yeah.
Yeah, I mean, I didn't understand those things until I went through them myself
Yeah.
as a mom.
Yes.
And I think that this book is very much a combination of lived experience
Good.
as well as clinical
Yeah.
experience. And so, unfortunately, I think that that's that's how so many of us get to where we are, what we were talking about the other day,
Agreed.
is a combination of lived experience and being like, "Hey, this" maybe that anxiety piece, right? But like,
Mm.
"This isn't working, and
No.
this didn't serve me."
No.
That was where this book came from, is I was
I
like,
love
if
it.
I fell through the cracks
Right.
as a clinician
Yeah.
with a decade of experience and all the training, all the resources, financial stability, a
Mm.
supportive partner, like family that's there. If I fell through the cracks, like
Yeah.
this isn't serving anyone.
No. 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 Not at all. In so many ways. In so many ways. And I appreciate that you point that out specifically to a lot of the work that I did in the domestic violence space and I've done over the years, which I am like so grateful for. I wouldn't want my life to have turned out any other way than it did because I'm here, now and see things in a different kind of way. Like you say you're so aware of being fortunate and having access to things and even still you experienced the bad stuff and the trauma. And, we were talking about practitioners, clinicians also have gone through trauma and, sexual assault and abuse and, again, with those stats. Yet you too are not, you have no, you're not trained in it or
Yeah,
not
we're not given
afforded the,
any
yeah.
support. No, we're not given any support in training.
Mm,
We're not given any support after, and we're not given any grace
mm,
is a big one,
mm,
right? So, like,
mhm.
God forbid something happens to a patient. Like, it happens to a patient and it also happens to the clinician,
It does.
right? Like,
Yes.
we experience, especially those of us who have like these big bleeding hearts, like
Yup.
we go through it with you.
Yep.
We care
Yeah.
with you
Yeah.
deeply,
Yep.
right? And
Totally.
I wouldn't say it's the same, but we grieve with our patients when they lose a pregnancy,
Yeah.
right? Like if there's a stillbirth, like that
Oh,
impacts
God.
us too.
Yeah.
But we're expected to then just like go into the next room like nothing happened.
Right.
And so I think that's the part is like we weren't given any support on how to navigate those moments.
No.
We're not taught how we can ask for help
Right.
if it's bigger than us. And that's the flaw, is
Yeah.
that we're never told, "You can be a human.
Mm,
It's okay to be a human."
mm.
And systemically in medicine, that's a huge problem.
Valid. And now that you even say that, I think all of us can take that in and look at our experiences and say, yeah, I've absolutely experienced that. And it is sort of like an us and a them kind of thing where, there has to be, or you want so desperately for there to be a connectivity and a thread and a humanity. And
Humanity.
yeah,
Yeah.
yeah, yep,
Yeah.
yeah,
Yeah. And I
yeah.
think that humanity has been stripped from medicine.
Mm. Thank heavens that you have articulated that and you're putting it out there for us to have access to and to think about. This is really thought-provoking stuff, Nikki. We're talking to each other. We're talking, meaning all of us, women, and we're creating communities where we share and hopefully, empower each other and ourselves and learn from each other because we're talking about things that hadn't really been talked about before
That's the goal.
openly, right? That's the goal.
That's the goal.
That's
That's
the
the goal.
goal. I can't thank you enough, really, for being here. I just can't thank you enough. Is there anything you would like to leave everybody with? Any kind of nugget or anything? I mean, we've talked about so much, and there's so many good things here. Anything?
Not much aside
Mm,
from just trust yourself,
mm,
right? Like,
mhm.
I think that that's the biggest takeaway is learning how to trust yourself and learning how to listen to yourself and
That's a big
giving
one.
yourself grace as well, I think is an important one. But a lot of these things come down to relearning patterns that we have been trained on, patterns that don't serve us,
Mm.
right? In society and in healthcare, it's the same patterns that show up. And so I think really learning how to trust yourself and your gut as you go through it, I think is really important.
I love that. And that is a work in progress
Mm.
for all of us, isn't it? It's a work in progress to trust ourselves and be able to identify what that feeling is here. When you have that feeling or you're like, I want that, but there's something that is just saying it's really not such a good idea. Or, and you can't put your finger on it, but you really need to trust that. You just have to.
Yeah.
Okay. Well,
Thank you for having me here. This was so much fun.
thank you. And let's do it again when your book is out, okay?
That sounds great.
All right, great.
Good.
Thank you so much for listening to this episode of Inside the Wellspace. Subscribe now on Apple Podcasts, Spotify, YouTube, or wherever you listen to your podcasts.